All right, can I go on?
Yes,
Yes,
you
you
can
can start.
proceed.
But I think I noticed this is still on record. Is it possible, or should I continue? I thought,
No, I had stopped for the MCQs and I've started
okay,
recording now. So go ahead.
okay. Good evening, my chiefs and my colleagues. Today, I'll be presenting ventricular assist devices under the following outline. Please, next slide. All right, next slide, please. Okay, I'll start by saying that a ventricular assist device, actually an electromechanical device that helps to support the cardiac function. Normally, these pump actually they can ideally partially or completely replace the function of a failing heart. We're talking about ventricular assist device as a support mechanism for a heart that is already failing. The purpose of this is to help to support the patients that have heart failure by increasing the perfusion and reducing the filling pressures in the heart. This ventricular assist device, they assist in pumping action of the diseased ventricle. And suffice to say that we only use it for patients who have advanced heart failure. And when these people who have advanced heart failure undergo this ventricular assist device placement, this device itself only augments. It does not completely replace the function of the heart. So these ventricles are just more of like used in augmenting. So what are the types of the ventricular assist devices we have? Normally, we have the two ventricles, the right and the left ventricle. When the right ventricle is only affected, you can use this device to support it. And at that point, you call it the right ventricular assist device. In a situation when the left ventricle is affected, and this as the devices are being used, it's termed the left ventricular assist device. Then in a situation where both are affected, it's called a biventricular assist device. Next slide. So how does this, we all know that the left heart, or rather the left ventricle is the biggest, and in cardiology, that's where most everybody almost always talks about. So we'll be talking more of the left ventricular assist device. So this device itself, it allows the left ventricle to actually function normal. What they do is that they help to, it's a device that's positioned outside the heart. And the major job they do is to help blood flow to maintain circulation in a patient's heart that is already failing. So it helps blood to exit the left ventricle to the aortic valve to the secondary to the native heart function. And the level of the function and the compliance of the aorta will determine the pulsatility of the patient. Next slide, please. Now, these devices, they're actually designed to act as pumps. And we're talking about this, but they have two types of pumps. They've been designed such a way they have two types, the pulsatile pumps and the continuous flow pumps. The pulsatile pumps, what they actually do is that they mimic the pumping effect of the heart, the way the heart pumps. That's what they do. But the continuous flow pumps, they're actually more of the newer version of the pumps. They're actually smaller and they have proven to be more durable than the pulsatile pumps. If we're talking about the continuous flow pumps, it works through mechanisms. It's either it works through the centrifugal pumping system or it works through the axial flow pumping system. Now, for the centrifugal pumping system, what it does is that it transports the fluid and it will convert this fluid from the rotational kinetic energy to a hyperdynamic energy flow. And this centrifugal pump flow, they actually have a very high flow rate capability. So most of the pumps that are being used now, that have been produced in such a way that it has this mechanism, this centrifugal pumping mechanism. While for the axial flow, what they do is that they walk through a propeller system. But in general, both systems, the one thing they have in common is that they have a central rotor containing permanent magnets. And these magnets help to run currents through the coils that are contained in the pump, which is already housed in those magnets. And when this rotor spin, they help to push out the blood. For the centrifugal pumps, the rotor is actually shaped to accelerate the blood circumferentially, whereby it causes it to move towards the outer part of the rim to help circulate the blood flow. While for the axial flow pumps, the rotors are more or less cylindrical with blades that are actually helical, and it causes the blood to be accelerated in the direction of the rotor's axis. So they actually have a central thing which is called the magnets, and it works through the electric currents. That's how these pumps work. Well, this is actually a pictorial view of what I just showed for for the pumps that walk through the centrifugal flow pump. There's the battery. He has an external battery, which is actually outside. Well, it's connected to the pump itself. If we look at the ventricle, there's a pump underneath it, which, okay, I can see this is the, actually, this is where the pumping occurs, but this is the battery that is externally helps to connect it to the heart to help it function properly. Next slide, please. So how do we classify these pumps? The simple classification for this pump is it can be classified into either a short-term or a long-term pump. Short-term pumps are pumps which can be used in acute setting, maybe just within a few days or weeks, or even just a month for patients who are maybe patient has an acute cardiogenic shock and perhaps the heart is not working well. You may need the short-term pumps for that, unlike the long-term pumps, which works for over a long time. That's so you can classify based on the duration of action, whether it's short term or long term. You can also classify it based on the pumping mechanism, which I already talked about, the pulsatile pumping mechanism and the continuous flow, and which under this continuous flow cannot be either a centrifugal flow system or an axial flow system. It can also be either a full assist or partial. Then it can also classify whether to either it has an assist device, which most of them are this ventricular assist that is against a total artificial heart. A total artificial is not classically a ventricular assist device, but it's just an artificial heart that the patient is using. And also, it can also be classified either based on paracorporeal or intracorporeal classification. Next slide, please. So how did pump ventricular assist device come into perspective into cardiology? Historically, it was noted that the very first left ventricular assist device system was actually created by Domingo Laiota at the Baylor College of Medicine in Houston, 1962 rather. However, not up until 1963, that was the very first time they had an implant of this ventricular assist device. But initially, the very first implant they did in that 1963 did not really work very well. So that very well failed. Next slide, please. Then in 1966, the very first successful implantation was noted. It was done by Laiota and also Dr. DeBakey in 1963 to a 37-year-old woman. The woman was said to have had a post-cardiotomy shock following an aortic valve replacement. And it was found out that they had to put a paracorporeal circuit, which helps the pumping system to work for 10 days after the surgery. Next slide. However, it was still noted that the very first successful, the long-term implantation was conducted in 1988. And this time was by Dr. William Bernard of Boston Children's Medical Center and Tamil Dixie. And this particular long-term implantation of artificial was what led to development of HeartMate along, while we will still realize it. Then Dr. Deontay Cooley reported the very first successful bridging to transplant using a mechanical support. But the very first successful implantation of a heart replacement therapy was by the use of the Tarjavik 700, and this was reported in 1984. Next slide, please. So this is more of like a pictorial presentation of what a left ventricular assist device looks like. This is with the battery that is powering the device, whereas this is now the device itself that helps this heart to pump. Next slide, please. So what are the indications for this ventricular assist device? The indications are grouped into an acute cardiogenic shock. First of all, if a patient has an acute cardiogenic shock and the heart is not functioning well, the short-term pumps can actually be used at this point. Then it can also be used as a bridge to transplant. But we were talking about bridge to transplant. It simply means that this patient already has end-stage heart failure and he's on the transplant list. Perhaps there's not been a donor, but for this patient to be alive, you need to keep this patient alive. You have to place this patient on that. So that's what this is for, is one of the indications as a bridge to transplant. The patient is already on list for transplant. However, the patient has not gotten a donor, but this patient must be alive. He needs to be on this device as a as it's an indication. And also for bridge to candidacy, it simply means that this patient already has had end-stage heart failure, but he has a contraindication to a heart transplant. But when you place this patient on this device, the patient's status may improve. Is also an indication. So bridge to candidacy means that there is a heart failure, end-stage heart failure. A patient is not qualified for heart transplant. There's a contraindication, but this device will help the patient to improve his patient's cardiovascular status to a little extent. Well, for bridge to recovery means that this patient's native heart failed, but when you place this patient on this device therapy, this heart improves on its own. And whenever you remove this device, the patient gets near total recovery of the function. But for destination therapy, for patients, they are all indefinitely on this ventricular assist device. These patients, they are not candidates for transplant, and they're actually patients, they will be on this ventricular assist device for life. So these are the indications for which patients may benefit from a ventricular assist device. Next slide, please. So if you will follow the American Heart Association and the American College of Cardiology Heart Failure Guideline, which is a 2013 review, actually, they said that mechanical circulatory support can be considered in selected patients with stage D heart failure with reduced ejection fraction with planned definitive management is a class 2A indication. Then for non-durable mechanical circulatory support, it's reasonable as bridge to recovery or even bridge to decision for selected patients who have heart failure with reduced ejection fraction with either acute or profound hemodynamic compromise, also a class 2 indication. Then durable mechanical support, circulatory support is also reasonable to prolong survival for selected patients with stage T heart failure with reduced ejection fraction. This is American Heart Failure Guideline for who may benefit. Then the next slide, please. Then also another thing, still under the American Heart Association, selection for ventricular assist device. Other patients also who can qualify for this ventricular assist device also include patients who have a left ventricular ejection fraction of less than 25%. And also is the New York Heart Association of stage 3 or 4 and has been on optimal medical therapy, but patient is not doing well, you actually consider this patient for also ventricular assist device. Then also if the patient has a high predicted 1 to 2 year mortality, when this patient has a markedly reduced peak oxygen consumption and clinical prognostic score, this patient also qualifies. Then if a patient has been on inotropic agents, patient is now dependent on inotropic agent, patient has heart failure and is chronically every time on inotropic agents, you need to actually consider this patient for a ventricular assist device. Then also the systolic blood for this last slide is for patients who actually have acute cardiogenic shock when the systolic blood pressure is less than 80 or 90 millimeter mercury, the cardiac index is less than 1 to 2 liter per minute per meter square. With an evidence of declining renal or right ventricular function, this patient also should be considered for a ventricular assist device. So what are the landmark trials in this ventricular assist device study? One of the trials that was done is for the HeartMate 2 left ventricular assist pivotal study. This study it actually began in 2005, and it actually included the evaluation of the HeartMate. HeartMate is one of the machines, or rather one of the ventricular assist devices that is being used right now. They considered it for two indications. They were trying to consider it for use as a bridge to transplantation and also as a bridge to destination therapy or long-term permanent support. The group which also the company that does the Thoratec Corporation actually announced that this was the very first time the FDA had approved a clinical trial to include both indications in one protocol. Then it was found that, next slide please, it was found that after the study was done, it was a multi-center study that was done in the United States. It showed that the patient had significant improvements in function after 3 months, and it had a survival rate of 68% after 12 months. And based on the 1-year follow-up from the same data, the FDA approved this HeartMate 2 for bridge to transplantation. So currently, HeartMate 2 is a ventricular assist device that has been approved as a bridge to transplantation. Then this clinical trial really provided evidence of an improved survival rate and quality of life for a broad range of patients. So currently, this HeartMate 2 is one of the devices that is used as a bridge to transplantation. Then another study it's still ongoing. This HAP study is still an ongoing study, and it is the Heart Recovery Protocol study, where they try to evaluate patients who had advanced heart failure, whether they require ventricular assist device support can recover sufficiently. So this HAP study is trying to do a bridge to recovery regimen, whether this ventricular assist device can support a bridge to recovery regimen. And the machine that was used was the HeartMate XVE, where they compared it and the use on oral medication therapy. And like I said, it's still ongoing. It's not yet, it has not gotten a final approval. The next. Then the rematch trial. This rematch trial is known as a randomized evaluation of mechanical assistance for the treatment of congestive heart failure. It trying to what it did that it was trying to end the sustainability of left ventricular assist device as a destination therapy. And from the study that was done, the FDA approved this rematch trial as one of the trials that's been used. Now, this is one of the trials that has been used in ventricular assist device, trying to know if you can use it for a destination therapy. So next slide, please. And also, this is the INTERPIT trial. This is also, it showed a significant advantage for patients with left ventricular assist device for destination therapy. But this patient, they were on ionotropes initially before they now started using this ventricular assist device to check for the trials for them. So it was actually used to compare patients who are on oral medication therapy and patients who are actually on ventricular assist device as a destination therapy. Next slide, please. So how does this left ventricular assist device help the heart? It helps by improving the arterial blood pressure. It improves the end organ perfusion. It also helps to decrease the left ventricular end diastolic pressure as the blood is actually dilated towards the left ventricular assist device itself. It also decreases the intracavitary pressures that lead to reduced myocardial oxygen consumption. And it reduces the left atrial pressure, thus decreasing the pulmonary congestion and prevents right ventricular failure. Next slide. So what are the limitations of this ventricular assist device? One of the limitations is that it's quite complex. Most of the machines are too complex to use. It's expensive. And most of them make use of an open heart surgery where you can open the patient and possibly insert the machine for further use. And also there is surgical expertise required. So these are actually the limitations to these ventricular assist devices. Next slide, please. Now, like I said, we have, well, I was classifying, we have the short-term and the long-term ventricular assist devices. Now, examples of the short-term ventricular assist device include the intra-aortic balloon pump, the extracorporeal membrane oxygenation, the Levitronic CentriMag, the Abiomed impeller, the Abiomed BVS 5000 and AB 5000. Then the tandem heart, these ones actually classified as a short-term ventricular assist device. So they're used on the short-term basis. And for the long-term ventricular assist device, you have three generations. They have undergoing some generational changes. The reason for this generational change is that initially the first set of machines were bigger, and over time, they're not trying to produce machines that are so small so that it can actually be compatible. So that was what led to these generational changes. And in classifying them, we have the first generation, and this first generation ventricular assist device, they make use of the centrifugal and pulsatile flow system, which I had already explained it in the slide. And the examples there were the Thoratec HeartMate XVE, the Thoratec paracorporal ventricular assist device, then the Thoratec intracorporal ventricular assist device. But for the second generation, which gave a rise to a better machine, they make use of the axial flow. And amongst them include the Thoratec HeartMate 2. And this Thoratec HeartMate 2 is one of the devices, or for now, the FDA approved ventricular assist device for bridge to transplantation. We also have the Javik 2000, the Micromed Debaki, and the Inco Berlin Heart. Then the third generation long-term ventricular assist device, which also makes use of the axial flow system, include the ventricle-ventral assist, the pterymodular heart, the World Heart Lever Core, the Thoratec HeartMate 3, the Heartway, and the Seculite Synergy. So now, just to talk about one or two of these taken from each of the generations, one or two, the intra-aortic balloon pump, like we all know, is the most commonly and widely used available method of mechanical circulatory support. Is actually used for patients who have cardiogenic shock. Traditionally, that's where this intra-aortic balloon pump is used. The mechanism is that it works by a counter pulsation mechanism, and it can also serve as a bridge to transplant, but for patients who actually in as a short-term goal or as a short-term ventricular assist, can also serve as a bridge to transplant. Perhaps the patient's heart is already, the donor heart is already, you can use this intra-aortic balloon pump as an indication there. Next slide, please. Okay, this is actually a picture of how an intra-aortic balloon pump looks like. To be frank, this machine is quite big for me, and I just had to put all this so that we can see what it looks like, what an intra-aortic balloon pump looks like. Next slide, please. So this ECMO simply means the extracorporeal membrane oxygenation. Actually, it's an artificial, it works as an artificial circuit, which helps to carry blood from the patient to a gas exchange. Well, it's an external circuit that it's outside. The patient is connected through, you can actually connect the patient either through the venous arterial or the veno-venous routes. And what happens is that the blood is drained from the patient into the oxygen concentrator. The concentrator is outside, and there's a gaseous exchange where the CO2 is taken away and the blood is enriched with oxygen. And this blood is now enriched with oxygen is now transferred back to the patient through either the central vein or the central artery. And this extracorporeal membrane oxygenation can actually serve as a bridge to recovery, a bridge to decision, or it can also serve as a bridge to transplantation. Next slide, please. Okay, this is just a pictorial representation of the extracorporeal membrane oxygenation. Like I said, we have the veno-arterial pathway. You can also have the veno-venous pathway, depending on the type. But what it does is that it takes away the blood from the patient into the oxygen concentrator where there's gaseous exchange, and it now transfers it back to the patient. Next slide, please. Now, the levotronic centrimag. It actually acts through an extracorporeal centrifugal pump. Then FDA has approved its use for up to 6 hours. So this can be used for up to 6 hours in its use. Then it has a less hemolytic effect and chances of mechanical failure. So for this levotronic centrimag, the chances of it failing in an acute phase is quite less. You can use a routine cannulation while using this levotronic centrimag. And suffice to say that it can pump up to 10 liters of blood per minute. So it can go as high as 10 liters per minute using this Levitronic Centrimac. Please, next slide. And this is just a picture of what a Levitronic Centrimac looks like. Next slide, please. Then the Abiomed BV5000. This is still part of the short-term ventricular assist device. It works through a dual-chambered, pneumatically driven extracorporeal pump. It has a flow rate of about 6 liters per minute. Initially, the FDA approved this for post-cardiotomy shock, and it's an easy machine to use. So this is what it looks like. So you connect it, and you can actually... Next slide, please. And for the tandem hearts, and this tandem hearts is said to be percutaneously inserted. He said that the inflow is through a femoral vein from the left atrium, wherever the outflow is into the femoral artery. The flow rate is up to, it can go as up to 4 liters per minute. And the tandem heart is said to be easy to insert. However, it's popular in high-risk patients, PCI patients, and patients with post-MI shock. This is a way you can use the tandem heart. And that's what a picture of a tandem heart looks like. Next slide. Then the Thoratec HeartMate XVE, this is a first-generation long-term ventricular assist device. It's FDA has approved it for both a bridge to therapy, a bridge to transplantation, I beg your pardon, and a destination therapy. It's electronically vented, it's portable, and it has its battery. It works through a pusher plate technology, and the mechanism is the pulsatile flow. It has a flow rate of 10 liters per minute, and in electronic failure, this Thoratec HeartMate can be pneumatically driven with a hand pump. So one of the good things about it is that when the electricity fails, you can use a hand pump. That would be quite cumbersome. And one thing is that it does not require anticoagulation, or rather, one patient that is using this thoracic HeartMate, you may not necessarily bother about placing the patient on anticoagulant, as only aspirin can help. And this is what it looks like, the Thoratec HeartMate XVE. Next slide, please. And the Thoratec paracorporal VAD, which is also one of the first generation, is can be used for a univentricular or biventricular support. So it can be either used as a left or right or both ventricular support, and it's used through a paracorporal placement, which allows implantation for patients who have a less body surface area. So for patients who have a less body surface area can benefit from this Thoratec paracorporal ventricular assist device. Then the pulsatile flow is about 7 liters per minute, and it requires a less dissection. So it does not need much opening out the skin to insert this machine. And that's what the Thoratec paracorporal looks like. Next slide, please. Now, this is Thoratec HeartMate 2. This is the second generation long-term ventricular assist device. And this for now is the only FDA-approved machine for bridge to transplant. It works through the axial flow rotatory pump. It's quite small, it's less invasive. It has a flow rate of 10 liters per minute, and the inflow is through the LL ventricular apex, while the outflow is through the ascending aorta. And suffice to say that for this Thoratec HeartMate, while trying to insert it there, you need to create a small pocket in the peritoneal space, which will help you to put the machine. And that's what a Thoratec HeartMate 2 looks like. Now, ventral assist. This is actually a third generation long-term ventricular assist device. It works through a centrifugal pumping system with hydrotically suspended motor. It has been found to be 82% successful as a bridge to transplantation, and there is no need for anticoagulation while using a ventral assist. Next slide, please. Okay, so that's what a ventral assist looks like. Now, device selection. So what are the things, further factors that you need to put in before selecting the device for a particular patient? The first thing, you need to classify this patient. What does this patient have? Does this patient have an acute cardiogenic shock? So if the patient has acute cardiogenic shock, it will give you idea of the kind of machine to use. Is this patient a heart failure patient despite optimal medical therapy, is not doing well and has qualified for transplantation, but at that point, this patient needs something to keep him going. You also need to classify the patient. And also patients, other congestive heart patients who are not transplant candidates and not yet evaluated for transplantation and potentially recoverable myocardium. These are the things that you need to consider all this before looking for the appropriate device to use at that point. Then also if the patient is a candidate for destination therapy. But for patients who have cardiogenic shock, you can also consider Abiomed BVS 5000, Abiomed AD 5000, and CentriMag. But for biventricular assist device patients who they help to decompress both ventricles and as well also it restores hemodynamic stability and provides enhanced peripheral perfusion for the patient. Next slide, please. Now, by bridge to therapy, like I already said, FDA has only approved for now HeartMate 2 for bridge to therapy. It's better than HeartMate 1. The reason is that it's smaller, it's quieter, it has a low incidence of infection, and incidence of device malfunction is quite reduced. So based on this, as what are the qualities? These are the qualities that have made HeartMate 2 to be approved for bridge for therapy. While for bridge to either recover or decision, CentriMag is one to consider more. The reason that it can switch to a long-term device if the need be. This surgery has an ability to switch to a long-term. Then for destination therapy, currently HeartMate XV is the only FDA-approved device, but suffice to say that HeartMate 2 and Ventricular Assist are being evaluated as a destination therapy device, which both are smaller, are comfortable, and they are long-lasting. Now, how do you insert a left ventricular assist? Like I said, one of the limitations of a ventricular assist device, it requires a surgical expertise and sometimes may require an open heart surgery. First, you need to consent and explain what you want to do for the patient. You make an skin incision. Then you create a pre-peritoneal pocket where the device will be put. When you expose this mediastin, you want to cannulate the aorta and the venous system. Then, first of all, you need to create a cardiopulmonary bypass. This is a surgical technique. I'm just trying to read out the steps involved. When you create a cardiopulmonary bypass, then there will be an outflow graft anastomosis to the ascending aorta. Then place the sutures. Then you need to do the device. When you de-air the device, after de-airing the device, you will now wean off the patient from the cardiopulmonary bypass and actuate this left ventricular assist device and now secure hemostasis and close up the space. Please, next slide. Now, what are the post-procedure management? For a patient who has received the ventricular assist device, the post-procedure management is divided into the early and the late. In the early post-procedure management, this patient has to be on antibiotics, at least from the pre-procedure to at least 3 days post-procedure. The patient has to, then if patient who has hypertension or vasodilatation, you need to place the patient on not a epinephrine or a vasopressin for vasodilator hypertension. Then if this patient develops possible some ventricular arrhythmias, you consider use of either amiodarone or lidocaine. Then for late post-procedure management, the patient needs to start ambulating as quickly as possible. You need to monitor this patient for signs of infection, and it's recommended that this patient will be followed up weekly for at least 1 month. Then for anticoagulants, for HeartMate 1 XVV patients who are for patients who are using the HeartMate 1 XVV, they don't necessarily require anticoagulants. But for patients who are using the HeartMate 2, the ventricular assist, and the thoraco intra and paracorporeal ventricular assist device, can start this patient on the vitamin K-dependent anticoagulant as well as a antiplatelet. But know that this anticoagulant and antiplatelet should be avoided in the very first 48 hours of the procedure. So what are the complications of the left ventricular assist device? It's recorded that bleeding is the most common complication due to the fact that Patients who are on anticoagulant for may tend to bleed, or there may be impairment of the normal clotting system, or patient may have had an acquired von disease. It can actually cause bleeding in this patient. And also the leak at the pump site has been shown to also cause one of the reasons why these patients may bleed. And it's said that for patients who actually have been patients who have been placed on this left ventricular assist device, you should have a target INR of 1.5 to 2.5, especially patients for the outpatient basics. Then infection is also another complication, and most times you occur at the pump site or even at the pocket where this assist device is being placed, or even at the drive line. And they typically present with localized warmth or erythema at the pump site, along with fever and leukocytosis. And the most common organism is the Staphylococcus aureus, has been found to be isolated most commonly. However, Enterococcus and other Staphylococci species have also been isolated. Now, when it comes to gram-negative organism, the Pseudomonas aeruginosa has been implicated and is said that and is advised that aggressive treatments with the use of appropriate antibiotics should be instituted whenever this patient actually develops this infection. Then also surgical revision of the driveline from the infection may also be needed. Then, however, if need be, the pump may be replaced. Then surgical debridement may be needed for different infections. And severe infections may warrant device explantation with the use of ECMO at that point or cardiac transplantation as definitive treatment. Next slide, please. Then thrombosis also has been found to be one of the complications of patients who are actually on this ventricular assist device. They've been found to develop thrombosis or even embolic events or even stroke due to the subtherapeutic anticoagulation. Maybe this patient was not properly anticoagulated or from the atrial fibrillation or even infection that has predisposed this patient to a hypercoagulative state. Then neurological, from this thrombosis, the stroke may also be one of the most related complications. And it's been found that both ischemic and hemorrhagic stroke can actually occur. And this has been attributed possibly to the obstruction of the inflow cannula or the formation of the blood in the pump apparatus, or even the outflow graft obstruction and subtherapeutic anticoagulation infection. And the risk of hemorrhagic stroke is due to the anticoagulation. Thus, there should be a fine balance to achieve the necessary anticoagulation in this patient. And also arrhythmia has also been implicated as one of the complications. And ventricular arrhythmias are common after the procedure, and placement of the cannula can cause reentrant circuits. The suction can also lead to contact between the cannula and the ventricular septum, which can also trigger an arrhythmia. And usually development of such arrhythmias can be managed by either a change in the device settings, such as reducing the speed of the left ventricular assist device to allow adequate filling and ventricular filling. The management of the variety of medications is usually successful. However, refractory cases require catheter ablation or device exchange. Then this is a man-made, and after everything, there's also a possibility that this device can also malfunction. So device malfunction is also a complication itself. Next slide. So I quickly want to talk about artificial hearts. I had to put up this slide as artificial heart because artificial is totally different from a ventricular assist device from what I heard or from what I read. And they said it's a surgical implanted mechanical circulatory system which is used to treat refractory heart failure that is not amenable to treatment with a ventricular assist device. And this treats patients with heart failure by increasing cardiac output and reducing the filling pressures. In contrast to a ventricular assist device, an artificial heart device completely replaces the function of the native heart, and both ventricles and most of the atria are excised during artificial heart implantation. So it is not a classical ventricular assist device. So when compared to ventricular assist device, artificial hearts are used infrequently. And this artificial heart, they have two rigids, the ventricles that each have two valves. Next slide, please. And one ventricle is connected between the vena cava and the pulmonary artery to pump blood to the pulmonary circulation, while the other ventricle is connected between the pulmonary veins and the aorta to pump blood to the systemic circulation. The most commonly used artificial heart rapidly shuttles in and out the polypharmac bladder, which is contained inside the ventricles. This action creates a systolic pumping action and a diastolic suction effect. This air travels to and from the patient through a large pneumatic tube that are tunneled through the skin to an external unit that contains a pneumatic pump, batteries, and the controller. Now, the controllers monitor the function of this pump, and it displays the battery power and also certain information. And it helps to generate an alarm to indicate if the battery is low and other abnormalities that require the attention of patients or caregiver. So this is how an artificial heart is structured. And next, this is more of a pictorial representation of what an artificial heart looks like. Next slide, please. So as a way of concluding, despite ventricular assist bias is a device therapy used for treating heart failure, the first thing is that the approach to management of heart failure includes optimizing such a way that you must first of all optimize an evidence-based oral medication therapy. And this guideline-directed medication must first of all be up-titrated to maximal tolerable doses. And in a situation when this fails and patient qualifies for a heart transplant as a mechanism, you need to first of all think about the devices which should be used and when indicated. Thank you.
Dr. Briggs.
Yeah, I'm here.
Okay, go ahead.
Okay, all right. Okay, thank you so much, Dr. Udenaka, for that extensive presentation. A job well done. So in the chat room, everyone is applauding you. Dr. Brown is saying thank you for a wonderful presentation, as well as Dr. Philomena is also applauding your presentation. I'm not seeing an electronic hand up. So I don't know, do we have questions? Any questions? Any additions to what he has just presented? Okay, Chief Ayudeji, I'm sorry, please, do you have any contributions to say as regards your experience with this particular topic? Chief Ayudeji.
Okay, Chief Florence, thank you, Dr. Miller, for a job well done. It was quite explicit. You went all out. I think we just need to pay attention. You can come in terms of oral, like advanced management of advanced heart failure, that is mechanical circulatory, different ones, like you said. Then in MCQs too, like all those definition, destination, reach to recovery. We need to know those different terms. Very important for us. Thank you.
Thank you so much, Chief Ayudeji, for your comments. We appreciate. I don't know, Dr. Oloso, do you have anything to say? Your mic is unmuted.
Hello, Dr. Briggs, I have something to say. I can't raise my hand because I'm sharing slide.
Okay, that's fine. Okay, so you have the floor. Thank you.
Okay, yes. Thank you once again, Dr. Chimeze, for a very, very comprehensive and simplified presentation. I really enjoyed it. One thing I want to point out that I didn't see you dwell on, the contraindications to implantation of the device. What are the conditions that you see in a patient that exclude them from having a left ventricular device placement? That is one. And then, is there anything that can be done in the case of severe aortic regurgitation? Because if you look at older literatures about LVAD, they'll tell you that severe aortic regurgitation is a contraindication. Is there anything that can be done in those patients?
Okay, sorry. Okay, thank you, sir, Chief Conte, for the question. Well, with respect to contraindication to ventricular assist device, uh, like I said, the patients who are bleeding, well, it's more of what do I say? It's more of a complication. But if patient is active bleeding, I think patient for that one should not be thinking about getting a ventricular assist device at that point. Please, I don't know the question. The next question you asked me, I can't remember. Could you just say so, please?
About severe aortic regurgitation, can you put an LVAD in patient with severe aortic regurgitation?
I didn't come across that, but I know for patient, I don't think you would use in acute. I think intra-aortic balloon pump is one of the contraindications. I think it's contraindicated in aortic regurgitation. That's what I can say now.
Yeah. So in addition to the bleeding diathesis, so if patients have a bleeding diathesis, so they are actually not an LVAD cannot be put in them. Okay. Or even if they have severe liver dysfunction that is getting their INR without anticoagulation above 1.5, they can't get an LVAD. Also, if you have patients who have right heart failure, they have right heart failure, they can't get an LVAD. So now you have to make a decision to do BiVAD, which you mentioned, when they have right heart failure. And also, if they have severe pulmonary hypertension, even without heart failure, if they have severe pulmonary, without right heart failure, if they have severe pulmonary hypertension, you cannot put an LVAD as well. And for the aortic regurgitation, severe aortic regurgitation was a contraindication. But nowadays, they've developed a procedure called the pack stitch for patients. But that one is applicable for patients who have severe aortic regurgitation that is brought about by poor coaptation of the leaflets. Okay. So they can put a stitch there that is called the pack stitch. It is just like what you do for mitral valve coaptation. Yes. So once you put the stitch there, then you can be able to now put the device and it will work well for them. Thank you.
Thank you, sir.
Okay, thank you so much, Dr. Conte, for that input. Okay, I can see the electronic hand of Dr. Maduka. Dr. Maduka, you can please have the floor.
Thank you very much. I want to thank Dr. Udenaka for a very, very good presentation. I don't think I've seen this topic this simplified, so thank you. That said, I want to follow up from what Dr. Conte said about the choice for an LVAD or a biventricular assist device. So there are assessment tools that can help us decide which to use. For instance, there is the CETO heart failure model, which can help us assess patients who may benefit from the ventricular assist device. So I think we can look up that. And then for patients that we think may benefit from biventricular assist device, there is this 5-point CRIT score. I don't know whether you came across it, which can help us know whether a patient, yes, sir, which can help us know whether a patient will benefit from biventricular assist device or to leave the patient with a left ventricular assist device. So it's called the CRIT score, CRITT. And so that's the score. So the C there is if the patient has a central venous pressure of greater than 15 millimeters mercury. The R is if the patient has severe right ventricular dysfunction.
Okay.
For the I, if the patient requires intubation or preoperative mechanical ventilation. Why the T? There are two T's at the end. So one is tachycardia, and then severe tricuspid regurgitation. So these are the components of the CRIT score. Now, how you make use of this CRIT score is that you assign 1 point to each of the parameters, whichever the patient meets. And so, according to the CRIT model, 93% of patients with score of 0 to 1 will usually successfully tolerate a left ventricular assist device. But if the patient is having a score of up to 5, 4, or 5, about 80% or more of patients with that score will rather benefit from a biventricular assist device.
Okay,
So
thanks.
that's the contribution I want to make. By and large, it's a very good presentation. Thank you very much.
Thank you so much, sir.
Yeah, sorry, a quick one. Then you left out the impeller too. Impeller device is also very important. Useful in patients with high-risk PCI, post-cardiotomy surgery, advanced heart failure. It's been found to be very useful, even in advanced cardiogenic shock.
Thank you so much. It was an oversight. Sorry. Apologies.
Okay, thank you so much. Chief Cyril, please can you share your experience with us as regards this topic? Chief Cyril. Okay, so going into the chat room, okay, Dr. Sambo is saying that the topic would have been preferred to be mechanical circulatory support devices. Others are applauding you. So Dr. Sambo is also saying Intermax clinical profile for the time frame to intervention, which can range from few hours to months. Intermax clinical profile for the time frame to intervention, which can range from few hours to months. So she's saying that the profile can actually range from few hours to months. Okay, so thank you so much, Dr. Sambo, for that. So Dr. Zakia is saying, thank you very much for this wonderful presentation. Please, I need more clarification on bridge to candidacy and destination therapy. Does it apply to patients with relative and absolute contraindications to cardiac transplants, respectively? I don't know, did you get what Dr. Zakia just asked? Dr. Chimisi, should I repeat the question?
I think I got it. He is asking bridge to destination and, all right, bridge to decision, bridge to candidacy, right?
Yes.
Okay, well, what I understood while I was reading is that bridge to candidacy is that patient has a contraindication to a hand transplant. But when you place this patient on a ventricular assist device, these patients are expected to improve. That's what the bridge to candidacy means. A patient has actually contraindications to heart transplants, but while they place this patient on this ventricular assist, that you find out that the clinical outcome improved. That's what bridge to candidacy means. But for bridge to decision, is actually used to support a patient until the patient's candidacy status is decided. So that's what I understood where I was reading for the slide presentation.
Okay, thank you so much. And she was also saying, does it apply to relative and absolute contraindications too? Okay, yeah. So that's for bridge to candidacy.
Candidacy.
Yeah, that's for bridge to candidacy. All right, thank you so much, Dr. Zakia, for that comment. Well appreciated. Okay, so Dr. Philomena is saying, why use anticoagulation in first generation and not in the second generation? Why are you not using the second generation? Why first generation anticoagulation? So Dr. Philomena is asking.
Well, literally, well, maybe if I'm outside, perhaps because of there's a generational change in the production of these devices. So for technology, perhaps the second generation has a better but they may not need more anticoagulation. They may not need anticoagulation because they are produced well. That perhaps maybe that's what I can answer now. I don't really have a concrete. Maybe I think if I'm reasoning it out that way, because of the generational change in the production of these devices, perhaps for every step in production, technology comes in and they will try to do something that will be better than the old previous version. Maybe that's what I'm reasoning out now.
All right.
There was no concrete reason that was given, but if I'm to reason it out, that's what I may have to say.
All right. Okay, so Dr. Philomena, are you okay with that? Or does anyone have an addition to that? Dr. Philomena, are you okay with that?
Yes, Chief. Yes, Chief.
All right then. Thank you so much. Okay, Chief Grace Akere Dolu. Okay, do you have anything to say, your experience as regards this particular question? Chief Grace, any contributions as regards your experience with this topic for today? Thank you.
Good evening, everybody.
Good evening.
Thank you for the wonderful presentation. As some which I was in transit, however, the parts that I heard were well delivered. So basically, just like Dr. Ayojiji said, we need to note those terminologies, the bridge to transplantation, bridge to destination, all those terminologies, they usually come out in the MCQs. And like he said also, it's the topic, 11th classes device, so definitely it's one of the management modalities in patients with advanced heart failure. So it's something we should, be able to talk about for orals. So basically, I think everything that is relevant has been mentioned in regards to this topic for exam. Thank you.
Thank you so much for that brilliant input. We appreciate. All right, so in the absence of questions and okay, I want to move over to the chiefs. I want to hand over to Dr. Okopi to take over for the chiefs. Okay. I'm so sorry. Let me do it. Okay, well, okay, Chief, you can actually go on. I wanted to hand over to Dr. Okopi.
Please hand over to him. I thought you were handing. Okay, thank you.
Okay, no, I'm not. Okay. Okay, so in the absence of questions and contributions from participants, I would want to hand over the class to Chief. Thank you so much, sir. Chief Okopi. Okay, thank you.
Thank you so much. Thank you so much, Dr. Florence, for the beautiful coordination. Thank you, Dr. Conte. And thank you, Dr. Chimezie, for the very good, detailed presentation. Despite the issues, you persisted and you made the presentation very interesting. So we'll just go straight to some of our colleagues. But before we start, I want to specially recognize a very, very beautiful personality, my friend, and one of the founding members of this particular group. She may not be able to speak, but just to recognize Dr. Adebowale Ijaola. Dr. Adebowale, I don't know if you can say hi to the house. We are so happy to have you around. It's always nice to have you. But if you cannot, you can just put it on the chat box. Thank you so much for coming. It's always pleasing to have you. All right, so I'll move over to Dr. Adeyanju. Please, can you make your comments and contributions, questions? Thank you.
Thank you very much, Chief Okopi, and special greetings to Chief Dr. Adebowale Ijaola. It's good to have you here tonight, ma'am. Thanks to the presenter too. I just want to speak about the exams. I think there was a particular station, I think it's station 2, where they paint a picture, a clinical picture of a man that just had sudden deterioration in his cardiac function. So it was like a clinical picture that you now have to talk about all this therapy. They now ask that what are the things that can cause deterioration? But they don't want you to stop there. They want you to manage the patient till the end. So of course, after mentioning anemia, infections, You have to get to a place that you mention LVAD, ECMO, and stuff like that. And as it has been said, it is all this bridge to candidacy, bridge to decision, bridge to recovery, bridge to transplantation. Let's know all those terminologies, not because they will come out in that form, but because they will paint a clinical picture around it. And you need to answer that question, whether in MCQ or orals. Then I think somebody has been trying to explain that bridge to candidacy. Yes, the person is not yet fit for transplantation or to make a concrete decision at that time. However, when you put the patient on a bridge, maybe LVAD or anything, the patient symptoms improve for you to go ahead to make a decision or to go for transplantation. I think that's the explanation behind bridge for candidacy. The other things that we should also know is that we should try and know, maybe if we can get some pictures of those, what will I call them now? Let's just have a picture in our head of all those equipment so that in case if a picture test comes out, we are able to quickly know that, oh, this is LVAD, this is BIVA, this is this and that. Because in the Light Cardiovascular Review Forum too, they actually dwelt so much on this mechanical support system. Thank you very much, and thanks for the opportunity.
Thank you so much, our beautiful Adeyanju, for always being around. Your consistency is quite impressive and encouraging. Thank you for the beautiful contribution. So we'll go to, let me see if we have any other person. Dr. Alison, please, can you make a contribution?
Okay, thank you. Thank you, Dr. Okupi. Good evening, Dr. Adibowale. Nice to have you around. I should especially appreciate the presenter. Your efforts are quite commendable. It's a broad topic, and I think you touched on so many things, which I think for the purpose of exam, you have to read those slides again. A lot has been said. Every aspect that you mentioned are very important. But MCQ, part of our MCQs that came out, it was not really enough to be able to mention those ventricular assisted devices. You must be able to class them into which generation they belong and the names of the particular ones in specific generation. Then after knowing those names for the particular ones in specific generation, you should also know how they function. The ones that use pulsatile flow design, the ones that use continuous flow designs. Those were the questions Prof was asking. So the continuous flow design, that's second generation. First generation pulsatile flow device. I think the one that came out in our exam was continuous, and it was the second generation. But it might not really have it as second generation. I think it has a specific name. Is it tandem heart? So that's the way we have it. So you should know the particular names of the ones in first generation and how they function. The second generation and how they function. The third generation and how they function. And what makes the third generation different from the other. And the point on aortic regurgitation and left ventricular assisted device is also very, very important. So we should actually know how we can manage those in aortic regurgitation and cardiogenic shock, what actually we can do. And if at all you are in a fix and you want to use, which one of them will you use? Then, which other question? Most other things have been touched on. I think the presenter did well, but it's an important aspect. There is a guideline, yes, for the management of heart failure in general. And there is a section in the ESC guideline that talks about these advanced heart failure. Then permit me to also mention advanced heart failure, refractory heart failure. There are two different entities which we should also know, be able to differentiate and which one leads to one and how we'll manage for OSCE sake now. So quite important. Thank you to the presenter. We appreciate your efforts. Well done.
Oh, thank you again, Dr. Allison, for that excellent contribution and for your exam experience. Doctor, let me just make one or two contributions and maybe ask you a question that will be more applicable and exam related. Let me just make some statement first with respect to severe aortic regurgitation and implantation of an LVAD. It's actually a complex issue for the following reason. You know, implanting an LVAD where you have severe AR, because you know there will be volume overload from the regurgitant flow, and that will reduce the LVAD effectiveness, and can also result in device. Oh, I don't know. Can you hear me? It seems my network is poor, right?
You're better now. You were initially. You're better now.
Contact. Can you hear me? Oh, I'm so sorry. My network is kind of poor. But if you don't hear me again, just let me know. All right.
Yeah, we can hear you.
So, all right. So severe AR can lead to volume overload, and that will reduce the effectiveness of the LVAD, and also it can result in device malfunction from device thrombosis, and the regurgitant flow can interfere with the LVAD function, and it can even worsen the heart failure. But just as Conte said, it doesn't mean you cannot implant an LVAD in the case of severe AR. With a concomitant aortic valve repair, you can do that. Even a TAVR, you can do it. And sometimes some persons have actually advised a complete closure of the aortic valve, since the LVAD can actually do the function. So in the presence of severe AR, you can actually do a complete closure of the aortic valve and implant the LVAD. Or you can do the TAVR, or what Conte said earlier. Just to add to the contraindications to LVAD, in patients with irreversible brain damage, there's no need to do an LVAD. And as Conte said, severe liver disease, end-stage renal failure, and acute ongoing infection is a contraindication, in fact, absolute contraindication to LVAD. And patient with irreparable mitral stenosis is also a complete contraindication. And the patient that just had a recent stroke, whether hemorrhagic or ischemic, within 2 to 3 weeks, within 2 to 3 weeks or so, I can't remember, but just within 2 to 3 weeks, it's a complete contraindication to LVAD. And they also said that patients with that are cachectic or with a small body size, it's a relative contraindication, but it's actually a contraindication also because of the inadequate space to implant the LVAD device. And then poor nutritional status, and if the patient is not compliant, and poor social support. And if there's any life expectancy less than 1 year, it's a complete contraindication to LVAD. I would love you to discuss the following things about LVAD. If you can give us the various parameters to monitor with respect to LVAD device. But that one, I will just maybe make a statement after you're done. But the question I wanted to ask would be, can you discuss the multidisciplinary care in LVAD management? Both, okay, if you find it in exam and they say discuss multidisciplinary care in LVAD, how would you go about it, Dr. Chimeze? You can unmute and try to answer. Let me see.
Chief, thank you for the question. Multidisciplinary LVAD is a multidisciplinary approach. The patients that involved, or the people involved, actually the cardiologists, the cardiothoracic surgeons, the social workers, even the palliative care specialists that are actually involved in management of patients that is undergoing this left ventricular assist device. It's a teamwork. That's what I can say now, Chief. You need to explain to the patients what you're about to do for the patient, because like I said, most of the procedures are surgical procedures. So the cardiothoracic surgeon is also involved in the procedures.
All right. right, thank you so much. That was a very good attempt. I don't know if we're recording, but that's really one of the being around our examiner. That's kind of question he'll ask. So, but you've tried, and by listing the teams that or the specialists that will be involved in such LVAD implantation is just to help you organize your thoughts. Although you know it, but just to help you organize it. You can organize them into pre-implantation evaluation, post-implantation care, ongoing management, and end-of-life care.
Okay, sir.
And then for the pre-implantation, you give the role of the cardiologist, which will do what? The cardiologist will evaluate cardiac function, optimize medical therapy, whether it's a refractory or advanced heart failure, and then select suitable candidates for an LVAD. That's the work of the cardiologist. And the cardiothoracic surgeon will assess the surgical risk, the appropriate anatomy. Of course, you didn't discuss with congenital heart disease and LVAD, but we can discuss that much later. So the cardiothoracic surgeon will assess surgical risk, evaluate anatomy, and also plan the implantation. Of course, you talked about the palliative care specialist. We discussed the goal of life, quality of life, and then the end of life preferences for the patient. And then the nurses who educate the patient, families, LVAD therapy, implantation, and post-care. During post-implantation, the cardiologist will optimize the device setting. And that's where I was going to ask you about monitoring and device setting, the different hemodynamics and co. But that's the function of the cardiologist. If cardiologists optimize the device settings, manage medical therapy, and monitor cardiac function, cardiothoracic surgeon will also manage surgical complication. The palliative care will address symptoms, pain control, and emotional support, and also the nurses. For the ongoing management, the cardiologist will monitor cardiac function, also adjust all device settings to ensure all the pressures are well monitored, the hemodynamic status, volume status are well within the acceptable limits of the LVAD. Of course, the palliative care will continue management.
I think we lost Dr. Conte and Dr.
Hello, I'm so sorry. My network went off again. I don't know if you can hear me, Dr. Chineze.
Yes, I can hear you now, sir.
All right, for the ongoing management, that was that stop. At the end of life care, you must discuss end of life care when you're managing this patient. Of course, that's where most importantly, the palliative care specialist will come up to discuss all the goals, the hospice transition, and end of life. The cardiologist will manage exactly medical therapy and also heart failure symptoms, and then the nurses. And for the cardiologist, during the ongoing management, of course, you discuss the parameters, the various parameters. Probably you'll add them later before you spend on the slide. How to monitor the cardiac output, the hemodynamic parameters to monitor as the cardiologist will be the cardiac output, the mean arterial blood pressure, the central venous pressure, right atrial pressure, the speed of the pump. Of course, increasing the speed, reducing the speed, what it will affect with respect to the left ventricular diastolic pressure and pulmonary capillary wedge pressure, volume status to ensure there's no volume overload. And also, of course, we discussed the pulsatile flow and the continuous flow setting, and also some individualized. And then not to forget echocardiography and ECG. And there is a guideline from ESD on how the regularity of your ECG immediately after the post-operative period, within the 1 to 2 weeks, you have to do daily ECG monitoring. And then after that, you do weekly ECG monitoring for about 3 to 6 months post-implantation, then monthly if the patient is stable. For echocardiography, you have to do weekly echocardiography, the immediate post-operative period, that's 1 to 2 weeks. Then 2 to 2 weekly for the next 3 to 6 months. Then quarterly, the patient is stable, then every 6 to 12 months. And then as the patient is improving, I think that's basically the questions I wanted to ask. And if you can probably add them up to your slides before you can put them monitoring and also the interdisciplinary support. Approach. Basically, that's approach. If he's going to ask any question in the exam, if it is in the orals, it might come this way, describing a patient that may need an LVAD after an advanced heart failure. And then you just say discuss. Yeah.
Thank you, sir.
Thank you very much. Yes,
Thank you,
thank
sir.
you so much. And yes, if you can also add that monitoring or
Yes, sir.
hemodynamic. Okay. I'm sure you saw
I'll
it
check
when
it
you
up
were
and put
reading.
it up, sir.
All right. And then maybe I'll check up all the definitions of bridge to destination and put it on the WhatsApp page for us to go through it.
Okay, sir.
Thank you so much, everyone.
Thank you
you.
so much,
I'm
Chief.
grateful.
Yeah. Yes,
Right.
Chief Okopi, sorry, just a quick one I forgot to mention. We should remember that LVADs are never used in preserved ejection fraction. So you don't have systolic heart failure, you cannot use LVAD. So even for patients with restrictive cardiomyopathy, is when they get to end stage and they now get concomitant systolic dysfunction, that's the time they can qualify for LVAD. But if you have preserved systolic function, you're only having problem with diastolic function, LVAD cannot help you. Yeah, thank you.
Yeah, very, 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 very clear and true. And then maybe it's too, for this, the basic part, I think for exam is okay. But with respect to specific conditions, with respect to ventricular assist device in congenital heart failure, constrictive pericarditis, restrictive cardiomyopathy, and co. They have specific details again. But for now, I think you did excellently well, Dr. Chimeze. Thank you so much for making yourself available to take your presentation. So I'll hand over the class to Dr. Florence for the next phase of MCQ. Thank you so much. Bye-bye.
Okay, so once again, I want to say thank you to our chiefs for their valid contributions. Your consistency and your show of love is well appreciated. Thank you so much. Thank you once again, Dr. Chimeze Udeneka. That was an excellent one. Great job. Thank you. We appreciate your efforts. So move over to the next. Yeah, you're welcome. Okay, so move over to the next session, which is the MCQs. Okay, thank you so much, Dr. Conte. So the next person to present, sorry, just want to go fast through the list. Please pardon me, sorry.
Yeah, while you do that, Dr. Ofosu, can you stop the recording and then start again so that it is separate?
All right. Okay, Dr. Eugene. Dr. Eugene.